Alright, so this would be a talk on subacute combined degeneration, and this is a part of a wider talk on spinal cord lesions, Syringomyelia, subacute combined degeneration, which we're talking about here, also Brown-Séquard syndrome, ASA stroke, Cotta-Equina syndrome, and spinal compression. So if you haven't reviewed the sort of the tracts and the neuroanatomy, I would highly recommend that you do that, just because it's really easy to lose all this stuff if you're not using it on a frequent basis. So the corticospinal tract is our main motor pathway, and that's going to start at the motor cortex, and it's going to send projections, upper motor neurons, down through the internal capsule, which run lateral to either thalami, and then they travel down the medulla and decussate at the lower part of the medulla. So once they decussate, then they're traveling on the opposite sides, and then they hit their synapse with a lower motor neuron, the second neuron in the system, which then travels out the anterior horn and to the muscle of destination. So really important to remember these tracts, just simply because it's much easier if you know these tracts. You can remember disease to lesion as opposed to disease to symptoms. A lot of symptoms which don't seem to relate to one another. Okay, the DCML tract is our sensory pathway for feeling light touch and vibration. And so because this is a sensory tract, we are going to be starting at the periphery. So we start peripherally, whatever mechanoreceptor or proprioceptor we start out with, and it travels to the posterior horn. At the posterior horn, it synapses, and it synapses with the second order sensory neuron. So we go first neuron and then to the second neuron. Now, the second neuron, it's going to travel up the DCML tract, which is on the posterior part, the dorsal part of the spinal cord, and it's going to decussate at the more superior part of the medulla. I don't know if superior, inferior are the best words, but what I want to get across is that DCML decussates superior to corticospinal tract. Okay, then finally the spinothalamic tract. This is our tract for feeling pain and temperature and crude touch. And this is similar to the DCML in some ways, but different in a couple key ways. So, like the DCML, it comes in from these endings, the nociceptors or thermoceptors, and it's going to, those nerves, those first order sensory neurons, are going to enter in through the posterior horn, like any other sensory neuron. And from there, it is going to synapse right away, and then decussate. So we're decussating with the spinothalamic tract right away. We're not waiting for the medulla. And so that's going to affect, if you have a lesion on your spinal cord, what side your symptoms are on, because the decussation for the spinothalamic tract is right away. And so once it's synapsed and decussated, and now it's the secondary neuron, the secondary neuron goes all the way up to the thalamus, just like the DCML tract, and then just like the DCML tract projects to the somatosensory cortex. So this I just made here kind of in relation to space, so you can kind of see where these tracts run if you were to have a cross-section. They're not really to scale, but that's not really the important thing. What I really want you to see is that for instance, the DCML runs in the posterior spinal cord. So it just like its name, dorsal column medial lemniscus, it runs in the dorsal or posterior column. Some people actually call it the posterior column medial lemniscus. So it's running here. It's in this light blue. I'm sorry, it didn't turn out as good as I wanted it to picture, but this is supposed to be a more shiny blue, and it travels upwards all the way to the decussation, and it decussates and it comes out anteriorly and more medially. It's more medial, and they're really more ovoid shaped, not circular. But this, as you can imagine, is called the medial lemniscus, and it travels to the thalamus. Okay, the spinothalamic tract, that synapses right away, and it travels, and it also decussates right away, and it travels on the opposite side on the anterior part, anterior to the anterior horn here. So it's traveling there. And then, of course, it's already done its decussation, so it doesn't have anything else to do. And then the motor portion is going to decussate inferiorly to the sensory decussation, and it's going to travel sort of on this lateral middle part here. Okay, so it's good to know sort of these parts of decussation and then where these tracts are relative to one another. And remember, with the motor decussation, that about 10% of the fibers will not decussate. So that's what you see here. This is the anterior corticospinal tract. That doesn't; those are fibers that never decussated. And then the majority of it, though, would be decussated on the opposite side. Okay. So subacute combined degeneration, simply put, is a loss of function of the DCML and lateral corticospinal tract due to B12 deficiency, although I would say probably anterior corticospinal tract may be involved too, based on some of the pictures I've seen. So the result is going to be a loss of fine touch and proprioception, as the DCML provides us, and weakness. The DCML is far more affected than the corticospinal tract is, so that's worth remembering. And this is a disease that is progressive without replacement. Not having B12 is going to make it so you can't make myelin, and it's also going to lead to byproducts that are toxic to myelin. So that's a problem. So this is a progressive disease if you don't replace B12. B12 is easy to replace, it's cheap, but it's a problem for people who don't take care of themselves. So this is your cervical spine here, DCML, corticospinal tract, and then of course your spinothalamic tract, which is decussating right away. When you have subacute combined degeneration, you are losing your mostly your DCML and parts of your corticospinal tract. And the symptoms of that are going to be loss of proprioception, vibration, and weakness. So causes of this can be alcoholism, pernicious anemia, malnutrition, mostly not getting your B12. People you would see that in would be like really hardcore vegans who don't take their vitamins, because you can really pretty much only get B12 from animal sources. And then celiac disease, if it's really severe, can cause B12 deficiency, as well as infection with the tapeworm Diphyllobothrium latum. And that is not because you're not getting B12, but because it's eating it for itself and laying its eggs. And then HIV and AIDS has also been associated with SCD. Okay, so those of you who've watched my lectures probably know that I really, really hate pathology and histology, and that's not to diss the people that do that for a living, because God knows that we need those people, but I find it completely useless for step 2 and step 3 because it's not going to be on your test, and unless you're going to be a pathologist, you're never going to have to look at stuff like this. So, that doesn't exclude the fact, though, that there are cases where having a histologic or a pathologic specimen and looking at it can give you a really good idea of what the disease is. And this is one of those. So what you see here is a cross-section of the spinal cord. I'm not exactly sure what cross-section it is, where it is. That doesn't really matter. So what we see here in purple is, this is stained. This is white matter. And what we see here in pink here is gray matter. And right in between these are your posterior horns. This would be your DCML. And just sort of to the just laterally, but in the middle here, so running right about here and right about here, would be your corticospinal tracts. So you have corticospinal tract running about here, and a corticospinal tract running about here. Remember that lateral corticospinal tract and the anterior corticospinal tract. And then your spinothalamic tract is kind of hugs this gray matter around the anterior part. So right about here and here in kind of like a J shape. So this would be your spinothalamic tract is. All right. Now, this is SCD. And so you notice here that this doesn't look right. There's pathology here. And so this is affecting your DCML. And so you can see that when you've got this this myelin issue of your DCML, it looks different. And this is even more full-blown. This is a different kind of stain. Don't ask me what kind. I gave up my histology knowledge a long time ago. But what's important is that you can see here that not only is your DCML affected, but look at, you've got your lateral corticospinal tracts affected. And it looks like your anterior parts are affected too, but I can't say that's necessarily the case. But definitely DCML and lateral corticospinal, with sparing of the spinothalamic tract, which would be right here. Okay. Now, I don't want you to get bogged down by this. What I just want you to know from this is that B12 is necessary both for to make healthy red blood cells and to make and also to make myelin, proper myelin. So that's why B12 not only gives you this subacute combined degeneration, but it also is going to give you a megaloblastic anemia. And these byproducts, homocysteine and MMA, if you remember back to hematology, these are the byproducts we use to measure lack of B12. The reason is because if you don't have B12, look at what's going to happen. You're not going to be able to turn homocysteine into methionine, and you're not going to be able to turn methylmalonyl-CoA into succinyl-CoA. And so it's going to cause a buildup of MMA and homocysteine. So both of these will be elevated in lack of B12. And it also causes macrocytic anemia. And so that kind of goes to the symptomology. So what do we see in patients with SCD? The history of these patients is going to be, a lot of times, they're chronic alcoholics. And so a lot of them may have a history of other issues related to alcoholism. So they may have Wernicke-Korsakoff syndrome. They may have depression. They may have other substance abuse or legal issues. Other patients, though, don't have alcoholism. They may have pernicious anemia. They may have celiac disease. They may have malnutrition. And none of this necessarily has to be already diagnosed. But these are things that you may see in their history puts them at increased risk for SCD. And the history of the illness is very gradual. So it starts, remember, very laterally or distally in your hands, fingers, or feet and toes, and it progresses more to more proximal sites. And a lot of times, it takes the patient a while to come in because if you're just getting, just a numbness of your fingers, it's not really necessarily going to get you in to see the doctor. So the symptoms are distal paresthesias resulting in inability to discern fine touch and vibration. A lot of times it's described as numbness or tingling. Fatigue and pallor are also possible symptoms that you may see, and that's symptomatic of an anemia that often coexists because these patients are B12 deficient. But a lack of anemia certainly doesn't exclude B12 deficiency. So SCD should always be considered in a patient with any risk factors like alcoholism or malnutrition who has these distal paresthesias. So when you prick these patients with a pin or the side of a, I don't know, something, whatever they give you to do your spinothalamic test, don't hurt your patient. They will feel that. But when you smack a tuning fork and put that on their toe, they won't feel that. So that's showing that you have isolated loss of fine touch and vibration. And so that shows that you've got DCML problems. And so this is going to, of course, depend on the progression, your physical exam, just because this can be really, really minor or it can be really severe. So that's all going to play into how your physical exam shows up. And a lot of times you'll see fatigue and pallor if they're B12 deficient, and rarely, in more severe cases, you may see ataxia. So for diagnosis, if you suspect SCD, the best test is a vitamin B12 level. So that's so easy to do because we get B12 levels on pretty much everybody who we know to be a chronic alcoholic. We know we get B12 levels on pretty much everybody who complains of anemia. We always get B12 levels on somebody who has a lack of fine touch and vibration distally. So this should be something that you do very readily. B12 levels are not expensive. This isn't like getting an MRI or anything. So the best initial test is a vitamin B12 level. However, there's other tests that can be done to corroborate your diagnosis of B12 deficiency. So you can get an MMA level, you can get a homocysteine level. Those are done, and you should know that they exist for the USMLE because sometimes the questions may not give you the B12 level, but they'll tell you you've got an elevated MMA and an elevated homocysteine, and that is the same as having an a deficient B12. Remember, if it's a normal MMA and a elevated homocysteine, that is consistent with folate deficiency, and that doesn't cause SCD. Very rarely is MRI performed. That would only be done in a clinical setting. That is never the right answer for the USMLE. So for the USMLE, if you're concerned about subacute combined degeneration, the best initial test is a vitamin B12 level, and it should be low. For differential diagnosis, and I'm sorry, this should say SCD, subacute combined degeneration, not Syringomyelia. Differential diagnosis is, I suppose you could include tabes dorsalis, which is neurosyphilis, and the part of the history you'd see in these patients would be a syphilis infection. They would have a normal vitamin B12, homocysteine, MMA levels, but a lot of these patients do have the similar peripheral losses of fine touch and vibratory sensation. Other things that you can see in these patients are the Argyll-Robertson pupils, which are pupils that accommodate they accommodate when they're looking inwards, but they don't react to light. And other features of neurosyphilis can be seen as well, like psychosis and personality changes and visual impairment. A lot of them will lose the ability to see color. Their visual acuity will go down, and that you don't see in B12 deficiency. So that would be neurosyphilis. But this can also give you vibratory loss or paresthesia. Multiple sclerosis can also cause vibratory loss and paresthesia, but with multiple sclerosis, when the patient first presents, usually it's in the relapsing and remitting form, so their symptoms will wax and wane. And also with MS, a lot of the history and labs are going to be inconsistent with a patient with B12 deficiency. So they're either not going to have B12 deficiency, or they're just not going to be that kind of patient that you would expect to have a significant risk for B12 deficiency. Most patients with SCD are older. Most patients, when they're diagnosed with MS, are younger. And most patients who have MS have focal neurologic weakness. Weakness is not really common in SCD. You can get weakness, but it's usually in the more progressed form. In SCD, usually the first thing that happens is that you're getting that loss of fine touch and vibration in your hands and feet. And then, of course, in multiple sclerosis, one of the more salient things is the visual deficits and eye pain, which is optic neuritis, and that's a very common way for MS to present. Okay, so treating subacute combined degeneration once we've made the diagnosis is pretty simple. We just replace the B12 that's deficient, and also tailor any other treatment towards the underlying or predisposing cause that caused them to become B12 deficient in the first place. So if they're an alcoholic, obviously behavior modification. We could also do a workup for pernicious anemia with a Schilling's test. We could also do antibodies for celiac disease, or if we're really thinking along these lines, we could also, and we're working in a patient that has possible exposure, we could also do a lower endoscopy for a tapeworm. And on that note, I actually this morning read about this guy in London who is apparently some kind of journalist or scientist who deliberately went and infected himself with a cow tapeworm, which he said are less threatening than the pork tapeworm. I think he's referring to different organisms, but yeah, this guy swallowed a egg of a tapeworm, and I don't know if he was trying to lose weight or what, but there are some crazy people out there. Don't do this. All right, I'll see you in the next lecture.